And we're back with our special coverage. We want to turn back to the big story of the coronavirus pandemic. Within the last few hours, the U.S. death toll has jumped to 31, and the number of confirmed cases nationwide is now approaching 1,000. Tonight, the New York Times is reporting that the failure of the federal government to allow for widespread testing all the way back in January may have certainly contributed to a wider spread of the virus. And joining me now is one of the authors of the piece, Sherry Fink, who wrote the piece in the New York Times. She is also a doctor. Dr. Fink, thanks so much for joining us. I appreciate it.
Of course.
So in your story, you write that a Seattle area flu study led by an infectious disease expert could have helped detect the coronavirus here in the U.S. as far back as January, and that this was a real missed opportunity. Explain to our viewers what happened.
So this is Dr. Helen Shu, and she's a collaborator, one of the scientists in charge of the Seattle flu study. And when that first case hit America, when we had our first confirmed case, it seems so long ago now, on January 20th, the CDC confirmed a traveler from China. She was contacted by the local health authorities saying, you know, we're going to trace all of this man's contacts. We're going to try to stay on top of this, make sure it doesn't spread here. But you guys are doing this unique study. And what they were doing is collecting hundreds of samples every day from people in the area who had flu-like symptoms. The goal was to sort of track the spread of viruses through a community. And so what better a resource to have on hand? Could they repurpose that to test for coronavirus? And the scientists said, yes, we'll get right on it. We'll create a test, we'll PCR, use little bits of the genome, and we could be ready to do this the first week of February to help these efforts.
And then what happened?
And then what happened? So they said, well, there's one issue, which is that we are a research lab. So our job is not to test clinical samples. There's actually a separate regulatory sort of infrastructure in the US for that. And that's to protect all of us, right? Because if we are going to be diagnosed with something, we want that lab to hit a certain standard. So she let the authorities know, you know, we're not a clinical lab. Technically, when we test for these things, we can share them among the research group, but there's going to be an issue to report that result. So can we get around it? And so very quickly, she and the state epidemiologist, Scott Lindquist, set about trying to ask that question. Was there a way that they could get around these regulations and bring this lab in? Could they send the samples, for example, if they had a positive test, could they send that over to the CDC to double check it? Because at that time, if you remember back, there was only one place that could test for coronavirus in the US, and that was in the Centers for Disease Control in Atlanta. So the amount of testing capacity in the US was very small. And so they kept hitting roadblock after roadblock. They would send these emails, and we have the emails asking the CDC, asking the state regulators, asking the FDA, can we find some way to do this? And at the same moment that was happening, there was a real problem with the CDC test. It worked in Atlanta, but when they sent on the first week of February, they sent out that test to the state public health laboratories all over the country, and they had trouble getting it to work. They had trouble validating it, testing it, and making sure it was working. And so that kept that testing capacity in this country so low for so long. All the samples had to be sent to the CDC. The definition of a suspected case remained very narrow. And as a result, as we see now, there has not been a great picture of exactly where this virus is in our communities.
Does this doctor in Seattle that you spoke with, does she believe that if the testing had been allowed, the outbreak of coronavirus in this country would have been more contained than it has been, which is to say it hasn't been?
Unfortunately, yes. And here's what happened was that on February 25th, the researchers had just had enough. And they said, you know what? We have thousands of samples now in our freezers from the Seattle Puget Sound area. We're just going to start testing them. And they thought, you know, this isn't a problem if we don't get any hits because we're allowed to test. And like one of those first runs that they did of the samples, they get a hit, they get a positive signal, and they realize that they have a case. And then they meet as a group and they are trying to decide, like, what do we do? Because technically we are not allowed to disclose that. So what's the right thing to do here? And they decided that the most ethical thing was to disclose that to the public health authorities. And what happened next was amazing, because it was a teenager. The state lab that day, February 27th it was finally able to start testing, had new CDC kits, confirmed the case, and found this teenager who was recovering, fortunately, as many young people, as we know, do pretty well with the virus, was just about to enter his school and or had just entered school, and they were able to find him, notify him of the test, and close the school for precautions. The sad thing, though, is that when the scientists, part of the Seattle flu study, sequenced that virus, they looked at the genome, and they were able, this scientist named Trevor Bedford was found markers in that genetic makeup of that virus in that teenager who had never traveled, who had no known contact with a case, but was from the same county as that very first case 6 weeks earlier in January in Snohomish County, Washington. And the genetics matched up. There was a very good chance that his case had descended, that there had been a chain of transmission possibly for 6 weeks in the Seattle area. And the modelers with the Seattle flu study estimated that there could be, at that point, 500 cases. So that was, that's really the point here, is that we were blindfolded for so long.
It's crazy. And Dr. Redmond, the head of the CDC, was bemoaning the fact either today or the day before that private labs were not doing more to help out. Here you have a private lab trying to do something, basically being stopped by the federal government, stopped by the CDC. How are the FDA and CDC responding this evening to your reporting?
So I took these findings to them many days ago, and I got to speak with the head of the CDC, and he said there were regulations here, and their hope, they did feel that Seattle, I mean, that's the irony of it too. They had identified Seattle as one of 5 American cities that needed a surveillance system. And they were hoping to get the regular flu surveillance system that we have in this country up and running to monitor the population, much as the Seattle flu study was willing to do. The problem was that the state didn't have the testing capacity at that point. So they just said it's difficult. And the FDA came back and said that, labs and, not this lab, but those private labs that you're talking about, the ones that are able to do clinical studies, can apply for an emergency use of their laboratory developed tests. But what my colleagues and I keep hearing from those test producers is that the steps are quite onerous to be able to get that FDA approval. But the FDA a few days ago did make that process a little bit easier, and they said that as of today they've had quite a number of applications coming in. So again, but we've kept hearing for weeks now, there's going to be expanded testing capacity in the US, and it's still, it seems to be really dependent on where you are in the country.
All right, Dr. Fink, thank you so much for your reporting. Really appreciate your time tonight.
Thank you.